So what I'll be talking about today is my research with Professors Nicola Paperno, Anna Goldenberg, and Marzi Gassemi, all of whom are faculty at the University of Toronto in the Department of Computer Science and the Vector Institute. And I'm currently a second-year master's student at the University of Toronto in the Department of Computer Science and the Vector Institute. So I'll be talking about differential private prediction in healthcare settings. So before I start talking about differential privacy, let's talk about anonymization and just how private it really is. So currently, there are a number of regulations around the world that govern the privacy protections for healthcare data. So in Canada, there's PIPEDA, in the US, there's HIPAA, and in Europe, there's GDPR. And there's different privacy protections depending on the use of healthcare data. So for example, I can see my own healthcare data without any privacy restrictions, as can my doctors and the nurses that care for me. And that's the same, for all individuals. But when we start to talk about using healthcare data for research purposes, or even trying to publicly release healthcare data, that's when we start to need stronger privacy protections. And that's when the regulations require stronger privacy protections. Currently, the gold standard for privacy protection for research purposes and public releases is anonymization. And so anonymization basically means that I will remove uniquely identifiable information like your name, and then I'll also randomize or noise certain parts of the data so that it's very difficult to re-identify you based on the anonymized version. But what recent research has shown is that anonymization isn't actually as private as we believe it to be. And with machine learning becoming a lot more prevalent, especially in healthcare, it's showing a lot of promise with being able to diagnose diseases and improve operational management of hospitals. And so research has shown that there's new privacy attacks that are able to predict whether an individual was used to train a machine learning model or to extract sensitive information about the individual's data that was used to train a machine learning model. So when we talk about anonymization, I want to look at this figure. And what this figure is showing is that, so let's say I am a hospital and I publicly release a healthcare data set of electronic health records. And so the public health record is on the left. And so it has information like the hospital, the patient's age, their gender, their zip code, the emergency code, so kind of what happened, what did they come in for? And then, so this is anonymized. So it's pretty hard to tell exactly who this corresponds to, which is good. But what can happen is that, so let's say I have this public news article or this public set of information that corresponds to a lot of the attributes in the health record. So for example, there's this news article on the right that basically shows, so that there was a 60-year-old man who was thrown from a motorcycle in Soap Lake and was taken to this specific hospital. And so it's pretty easy to link the information from this public news article to this publicly released health record. And so you can see the 60 years old and the location, but what isn't in the health record, because it was anonymized, is the name. But the name is in the news article. So because of that, it's pretty easy for me with high probability to now re-identify that this health record belongs to Ronald Jameson, because the news article includes all of the data that was in the health record, but then also includes the name. And so this is where anonymization starts to break down and is not really private enough, especially given kind of these new discoveries. Going further, we starting to think about private-public partnerships in machine learning for healthcare, where what happens when a private corporation such as Google or Amazon or Apple starts to collect healthcare data or purchases healthcare data from hospitals or has research collaborations with academic hospitals. So a good example of this is when Google and the University of Chicago's medicine department shared electronic health records, and then a patient sued both parties because of the fact that there wasn't consent given. But the thing is that the data was anonymized, and so the thought is that there's no re-identifying information. They can't really, neither Google or the University of Chicago can tell that this patient was in the data set. But if we think about just how much data Google, Amazon, Facebook, and Apple collect about us as individuals, specific behaviors, specific purchasing behaviors, our addresses, or location. And so they have all this information that they store. And so it would be quite easy for them to relink and re-identify, an anonymized set of health data that they get with the data that they have on different users, just through like our search behaviors and our social media behaviors as well. And so what I'll show next is that differential privacy gives us a really nice way to enable these private-public partnerships in machine learning for healthcare, but it also protects patient privacy from these potential linkages that private corporations, which collect so much data about us, can do. So what is differential privacy? So it's a rigorous definition of privacy that's robust to both membership and attribute inference attacks. So membership inference attacks in the machine learning context are, so if I have a machine learning model and I train it on a set of patient data, a membership inference attack is when a malicious user is able to infer whether an individual whether a patient was used to train that model. And then an attribute inference attack is when a malicious user is able to extract a sensitive attribute. So it could be like a health status, or it could be, like your socioeconomic status or whatnot. And so they're able to extract that information from the machine learning model that was trained on patient data. So differential privacy protects against those attacks. So how does it protect against those attacks? So let's say, I have this first database and I have this algorithm that's trained on this database of patients, and it produces this set of outputs. And then I remove one patient, and now I train the same model and produce another set of outputs. What differential privacy ensures is that these sets of outputs are approximately the same, regardless of whether I remove or add an individual. And so what that means is that it's hard for an adversary or a malicious user to tell that there was a difference, or to tell that one individual person was removed from the data set, which prevents them from being able to infer whether they were used to train a model or not. So the best way I like to think about differential privacy is that the outcome of a differentially private analysis on a data set is approximately the same with or without one individual's data. And the reason I say approximately is because the approximation is how we measure the privacy level. So the closer that these two sets of outputs are to each other, then the more private the machine learning model is, and the farther away, so the more different that these outputs are, then the worse the privacy is, and the less private the model becomes. Now, as I said, machine learning in healthcare has shown a lot of promise, and it's becoming quite prevalent. But it is very different from a lot of the really popular fields of machine learning right now, like computer vision and natural language. And why is that? So first, we really need good utility and model performance for infrequent and rare diseases. So if an outcome happens in maybe like 5% of the time, we still need to be able to perform really well in identifying those cases. The next thing is that the populations of patients and the treatments and the hospital policies are constantly evolving. And so I can train a machine learning model on data from 1 year and then have it predict on patients in future years, but the populations might be different. And machine learning models right now, they tend to perform really poorly in that kind of setting when the population changes. And so we need to make sure that machine learning models don't perform poorly and that they don't fail when the population starts to change over time. The next thing that's really important is ensuring that the predictions and the quality of performance is equitable and the best that it can be for all individuals, no matter of your sex or your ethnicity, and the intersections of those, or like socioeconomic status. We want these predictors to be the best that they can be for all of the possible, for all individuals. And finally, as I mentioned, we need better privacy protection because the current regulations just haven't kept up with the pace at which security breaches and technology is moving. So the thing with machine learning for healthcare is that we need to be able to simultaneously achieve all of these at once for us to be able to really use it in a trusted manner. And of course, there are other objectives that I haven't mentioned that I don't focus on in my research here, like interpretability and explainability of the predictions of machine learning models. So what I'll be talking about today is what happens right now regarding those objectives when I train models for machine learning for healthcare using differential privacy. So we focus on two data sets. The first one is Mimic3, which is an electronic health record data set. So electronic health records, they store information like labs. So like whether you have so you might have had a blood test. They store your vitals, for example, your heart rate, your oxygen levels, your blood pressure. And so we have, and so what we extract is we focus on an ICU setting. And we extract about 21,877 unique ICU stays over the course of 2001 to 2012. And this is from a hospital in Boston. And then the format of the data is time series. And so you can imagine, and so what that means is essentially I have a series of values like labs and vitals for every hour over the course of the first 24 hours of a patient stay in the ICU. And what we look at in this data set for regarding fairness is the disparities in the model's performance between white patients and Black patients. And the prediction tasks that we're interested in are mortality, so whether a patient died during their stay in the ICU. We're interested in length of stay. How long did a patient stay in the ICU? But we turn this into a binary prediction task where we say, did the patient stay in the ICU for more than 3 days or less than 3 days? And then finally, we focus on whether a patient needed to have a vasopressor administered to them during their stay. The reason we choose these three tasks is because there's varying levels of how often the outcome occurs. So in mortality, the outcome occurs not that often. So about 7.4% of patients died in our data set for mortality versus about 40% of patients had to stay more than 3 days in the ICU, and about 43% of patients had to have a vasopressor given to them during their stay. And so this gives us the ability to measure how useful differentially private models are when the outcome is infrequent, but also when the outcome is more frequent. And then we focus on another commonly found data type in machine learning for healthcare, which is medical imaging. And we focus on chest x-rays from the National Institute for Health in the US. And so we get about 112,000 and 120 chest x-rays, and we measure the difference in performance between male and female patients, and we focus on a multi-label, multi-class disease prediction task. And so the reason it's multi-label is because an individual can have a chest x-ray taken and there can be multiple findings that a doctor may find. So for example, you could have a pneumothorax, but you could potentially have a mass that's found at the exact same time. And so it's important that the models are able to predict both of these findings at the same time. And with this task, for each of the labels, the occurrence of the disease varies. So the most commonly occurring disease occurs about 20% of patients, and the most rare disease occurs about 2% of patients. So again, this gives us the ability to measure how useful are differentially private models when the disease happens very infrequently. So the first question, I kind of bring attention to is, I mentioned these privacy attacks in machine learning. And so the first thing to think about is are they a problem? Are privacy attacks possible on models that are trained using healthcare data? And the answer to that question is yes. So when we look at the models trained with no differential privacy, they have a 72% chance. So a malicious user has a 72% ability to predict whether your health data was used to train the machine learning model. And then when we use really strong privacy, so high levels of differential privacy, the performance of an adversary or a malicious user goes down to 55%. And so 50% is random chance, and so that's kind of the best that we can do. And so high differential privacy gives us kind of the best that we can, very close to random. And so that's really good, and shows that if we want to protect patients' information when it's used to train machine learning models, we need to use differential privacy because these attacks are possible. So the first thing I'll focus on is the trade-offs between privacy and utility for when the outcome is infrequent. And so we train both logistic regression models and neural networks using differentially private stochastic gradient descent. So differentially private stochastic gradient descent, also known as DPSGD, is just one method of training machine learning models with differential privacy. There are a number of different methods, but we choose DPSGD because it has optimal theoretical guarantees, and also because it applies to all of the different models that we train. So the first thing to notice, on this table is let's focus on the mortality task. So in the mortality task, which is the one where only 7.4% of patients experience the outcome, of death here. And so we see that with no privacy, there's an 82%, like the model performs with an AUC of 82. So the AUC, which is the area under the curve, we use that because that's what's commonly used to measure the performance of medical diagnostic tests, which I hope that one day machine learning will be a part of a part of existing diagnostic tests. And so so without privacy, we see that it's 0.82, it's 82, which is quite good. But with high privacy, the performance of the model drops 22%. In the mortality task for the logistic regression model, and the drop is even worse in the recurrent neural network model. And so this is concerning because it means that differentially private models right now have difficulty kind of predicting making good predictions when the outcome doesn't occur that often. But then when we look at length of stay, where the outcome occurs much more often, the drop in performance is much less. It's only 9%. And so the trade-off is better when the outcome occurs more. And then when we go to the chest X-ray classifier, where there's a number of outcomes, and also these outcomes occur in varying frequencies, all of which though are less than at least 20%, we see that the performance of the model drops significantly, and it's now a worse than random classifier, so it's completely unusable. So this is concerning, but the thing to keep in mind is that we do need this privacy protection. And so what this shows is that we still have a lot of work to make sure that find improvements to differentially private learning so that we can reduce these trade-offs when the outcome doesn't happen that often. The next thing I'll talk about is what happens when the population or the treatments or the policies evolve over time. So in this graph, first we'll focus on the mortality graph. And so the burgundy lines represent models that were trained without privacy, and the purple lines represent models that were trained with privacy. And so what's interesting about the MIMIC3 dataset, if you remember, so the electronic health record dataset that we use, is that we have the timestamps from 2001 to 2012. And what happened in the hospital was that they used the same software system from 2001 to 2008. So all the data was collected on the same software system for those years. And then they switched the software system after 2008 up until 2012. And so now the data was collected with one software system from 2001 to 2008, and then a different software system from 2008 to 2012. And so what prior research has shown is that models trained without privacy, if I train a model on all the data from 2001 to 2008, and then I test the model on patients from after 2008, so after the software switched, the model tends to perform much worse, which is what you can see here in this gray bar. In this gray bar, which is when the software system changes, that the performance is above 80, and then it goes below 80 because of the switch in the software system. And so what we're interested in is that, differential privacy has optimal theoretical guarantees regarding this kind of being able to be robust to switches and shifts in the data. And so we wanted to see, does this hold in a healthcare setting? So what we find is that for mortality, it does hold nicely. And so you can see the model doesn't drop, the model's performance doesn't drop as much as it does without privacy in the high privacy setting. And it kind of goes up for the neural network model, which is the dotted purple line. But the thing you have to caveat this with is that you have to remember that the utility for the mortality task was quite low. And so it's hard to conclusively say whether this is, whether it really is more robust to these kinds of evolving populations and the evolving data over time. Because what we see for length of stay and for vasopressor administration is that the performance drops even with high levels of privacy. The performance drops when the software system changes. So there's not really anything conclusive right now on whether differential privacy can help be robust to these evolving populations. and maintain its performance over time. The next thing I'll talk about is the trade-offs between privacy and fairness, which are very important. So looking at the difference in recall between white and black patients for mimic-free mortality and the length of stay, we see that there's not really any big differences without privacy or with privacy. And so measuring it through like a statistical measure such as recall and just checking the difference doesn't really give us a strong understanding of whether differential privacy improves fairness or whether it makes the models more unfair. But again, the issue is that these models have very low utility. So it's hard to know whether this is due to the low utility. So we try to understand it. So we try to understand the fairness from a different perspective, which is how do different groups of patients influence the predictions for other patients? Meaning that if do patients that survived help give us better predictions than patients that died? Or for example, does the majority ethnicity group give better predictions than the minority ethnicity group? And try to answer questions, try to see how does differential privacy deal with those kinds of questions in terms of fairness. And so what we find is that first looking at models trained without privacy. So in this graph, the orange points represent the impact that the group of patients that died had on giving us good predictions. And then the blue point represents the impact that the impact that patients that survived, so the majority class in this setting, the impact that they had on giving us good predictions. So points that lie above the dotted line are helpful. They help us give good predictions. So what you can see is that when we train models without privacy, the patients that died help give us the best prediction. And the patients that survived work against us, and they start to go against giving us the best predictions. And so that's what helpful and harmful stands for on the y-axis, is that helpful meaning that the group of patients helped give us good predictions, harmful meaning that the group of patients worked against giving good predictions. Now, what happens when we introduce high privacy, so strong, high differential privacy? What we see is that the impact that patients that died gets minimized. So it goes towards zero, meaning that they don't really have an impact at all on the kinds of predictions that we get. And so this is one way to think about why the models really perform poorly when the outcome doesn't occur that often, which is because by design, so the way that differential privacy was designed is that it has to put more work into hiding patients that, or individuals that don't occur that often or are dissimilar to the majority because they're more uniquely identifiable. And because of that, it has to learn less about those individuals. And so because patients that die have occurred less frequently than the patients that survive, differential privacy has to learn less about them right now. And so that's why what you see in red with the high privacy graph is that they don't really have an impact at all on whether we can get on getting good predictions. Now, looking at this from comparing the performance between white and black patients, what we see is that when we try to understand what patient group helps give the best predictions for black patients, we find that models trained without privacy, it's that black patients are helping give the best predictions for other black patients. But what we find is that when we introduce high levels of privacy, or even any kind of privacy, so both low or high, what happens is that now white patients are having the best or are helping give the best predictions for black patients. And so the thing to really consider, and this is a really important thing to consider, is that the use of ethnicity in medicine is, we're still trying to understand it. We're trying to understand, how do we fairly use ethnicity? Should we be using it at all? And so this is a very strong assumption for models that are trained with differentially private to make, is that the majority ethnicity should, or like making it so that the majority ethnicity influences and impacts good predictions the most. And so this is something to consider, and something that, from the machine learning for health perspective and from the differential privacy perspective, we should try and understand whether, is this desirable, is this not desirable, and what are the design choices that we need to make going forward, when we train models with differential privacy, to account for majority groups having influence over the predictions that minority groups receive. So other important considerations to take into account is that some of the solutions for, for improving, differentially private models, especially when there's, when the outcome it doesn't occur that often, is use some small amount of public data and to fine tune your differentially private on small amounts of public data. The thing is that in healthcare right now, unfortunately, public data is really hard to come by. It's really hard to come by public data. We can't, and I look forward to a future where more health data is public for research purposes, but it's not the case right now. And so that's not really a solution currently. And then the second thing to think about is that one of the solutions, based on the way that differential privacy works, as a framework for giving privacy, is to give less privacy to the minority groups, or like the groups that happen in not that often, the individuals that happen not that often. But so this is a really good diagram from a presentation that Dr. Cynthia Dwart gave this year, where she describes how, not everybody gets to trust and gets to have, less privacy or gets to trust society equally. So my interpretation of this is that most often the minority subgroups will want and will need to have stronger privacy guarantees because they are not able to trust society as much as the majority. And so giving them less privacy is the opposite of what they will most likely want. And so I personally believe it's an unethical design choice. And so we need to find a way to build differentially private learning algorithms and to train differentially private models that can give the same level of privacy to all individuals, or give them each their desired level of privacy, in accordance with this graph of how not everybody gets to trust society the same, and so different individuals will most likely want different levels of differential privacy. So what are the future directions? What are the things that I'm thinking about? What are the things that I think, I'd really like to see the broad machine learning for healthcare, the healthcare community, and the differential privacy community think about? So the first one from a technical standpoint for me is, how do we make differential privacy fair for all individuals, where we give them the same level of privacy, we can also guarantee them approximately the same level of performance, instead of just the majority getting the best performance. And then the second question is, how can we start discussing moving towards differential privacy as the gold standard when we share clinical data, instead of anonymization, which, as I talked about in the presentation, isn't as private as we once thought it was. So how do we engage the right individuals in hospitals, in academia, in the private sector, to start pushing for this being the new gold standard of privacy in healthcare? And with that, thank you for listening, and I want to thank my advisors for just helping me along the way, and helping with this paper and being great collaborators. And now I'll take questions.